Canada, land of universal healthcare. But is it really? Before claiming that title, we must first take a step back and tackle the barriers preventing access to healthcare for many Canadians. This video will address three major barriers of access: ethics of elderly care in Canada, accessibility of primary healthcare for Indigenous people, and finally, accessibility and availability of public transit. The ethics of elderly care in Canada is muddy. Where paternalistic, institutionalized healthcare systems, such as nursing homes, have relied so heavily on medication-based treatments, it has also diminished the autonomy of elderly patients, as their personal concerns are often dismissed as either irrational or senile. In a 2015 study by McRae of Mount St. Vincent University interviewed 30 Nova Scotian women between the ages of 55 and 89 about their experiences and preferences with institutionalized general practitioners. Interestingly, attentiveness and respect both ranked ahead of actual competence and wanted physician traits, suggesting that the interviewees first and foremost value being acknowledged as a person with agency. McRae found that although more than half of interviewees did not mind whether or not their doctor was female, many interviewees still noted that women physicians are preferred as they are seen as better listeners. The women also mentioned modesty and the ability of female doctors to empathize with them as a large factor as well. This finding was further supported by the work of Milligan and colleagues who looked at the changing geography of care. More specifically, they noted the fundamental differences observed in male and female caregiving, where the women tend to focus on personalized care rather than financial stability or home maintenance. To move forward from the abuse and mistreatment of institutionalized care, there has been a growing shift towards care being administered by either the community or even at home. Pursuing these changes will imbue more autonomy, humanity, and ultimately access to the healthcare they deserve. Another barrier is the state of Indigenous on-reserve accessibility to healthcare. Systematically marginalized throughout history, the Indigenous people continue to suffer the effects of discrimination and neglect, as unclear government policy underfunds geographically isolated reserves. Around 47% of Aboriginal peoples in Canada live on reserves or remote areas, and many of whom have no road access. In the remote Ontario reserves, physicians are distributed at low density, which makes them high in demand and hard to access. A study conducted by Shaw and colleagues showed that Aboriginal groups had higher hospital admission rates for ambulatory care-sensitive services compared to the general Ontario populations. Ambulatory care services, or ACS for short, are conditions that are normally manageable in ambulances. This finding suggests a lack of accessible primary healthcare facilities, which in turn is putting unnecessary strain on emergency services. The barriers caused by lack of government funding and neglect has contributed to poor infrastructure and under-equipped clinics, shortages of support workers, including trained Aboriginal professionals who could communicate linguistically with Indigenous peoples. Thankfully, geographic methods such as GIS initiatives could locate and identify key geographic areas of need, especially as Aboriginal participation in health service planning is beginning to develop. The Indigenous communities would soon be able to choose how they access their care. Access and availability to public transport is one of the most common barriers of access. According to the Ministry of Transport Ontario, the municipal transport offers conventional services such as buses, subways, and trains, as well as specialized services such as wheelchair taxis. But because both TTC and Wheel-Trans services are not always accessible for the elderly, the only other alternative is to arrange far and expensive private transport. Finally, in a study conducted by Habjan and colleagues on the barriers to health for the elderly in First Nation communities, it was found that in small communities with unreliable transit, it would on average take an hour by car to access a larger community. This is especially problematic for elderly who cannot drive. In order to make health more accessible, strong community involvement and good policy making will be the minimum requirement.